First of all, I would like to thank the organizing committee for invitation to let me speak today on the PrEP regimen for HIV prevention. This is my disclosure. This is an overview of my talk. I'm going to start with the evidence of using Tdf-FTC and on-demand Tdf-FTC for HIV prevention. This is so-called the first generation of PrEP. And then I'm going to move on to use of Tdf versus TAF. TAF is new agent that can be used in combination with FTC for HIV prevention. And lastly, I will focus on the cabotegravir long-acting agent, which is a new agent that acts as long-acting and can be used for both treatment and prevention. There are some studies that look at the efficacy of cabotegravir long-acting for HIV prevention among people with high risk for getting HIV. And then I will end with future and challenges in HIV prevention. Despite we having advanced on HIV treatment, in 2020, we still have new people who were newly infected with HIV. So we have advanced on the treatment, but we still have the problem with HIV preventions. And currently, we don't have HIV vaccine for prevention of HIV infection. So we need another tools for prevention of HIV. For example, we need some behavioral intervention and biomedical intervention for HIV prevention. PrEP is the combination of antiretroviral agents that used for prevention HIV transmission among people with risk. Ideally, PrEP regimen should work across among the population with risk. For example, men who have sex with men, transgender women, heterosexual individuals, people living with intravenous drug, pregnant women, and adolescents. PrEP regimen should have simple adherence and allow forgiveness for people who might not be adherent to the prescriptions. PrEP should be easy for self-administrations. And PrEP should have long-term safety and long-term tolerability. And the other important aspect or issue of PrEP should be inexpensive and can be accessed by people who want to use it in the affordable price. And PrEP regimen should be practical for implementation for nationwide policy. This is the ideal PrEP that we want to have. Next, I'm going to move on to the evidence of using Tdf-FTC for HIV prevention among people who have risk for HIV. Tdf-FTC has been used for HIV prevention for many years. And this is the timeline of the major study that looked at the efficacy of Tdf-FTC for HIV prevention. It started in 2007. Tdf were used for HIV prevention among people who have risk. And in that study, they found that the side effect of Tdf was low. And then in 2010, there was a major study called IPREC study that looked at the efficacy of Tdf-FTC versus placebo in men who have sex with men and transgender women. In the study, they found that risk reduction for getting HIV in Tdf-FTC was 44% comparing to the placebo. However, in people with good adherence, the efficacy was nearly 100% for HIV prevention. So IPREC was the first major study found that Tdf-FTC could be a good candidate for use as a PrEP regimen in MSM populations. And then in 2015, PrEP study conducted in the UK looked at the efficacy of Tdf-FTC given immediately versus defer daily Tdf-FTC for 12 months in MSM populations. In that study, PrEP study found that there was a reduction of HIV incidence in people who received immediate daily Tdf-FTC about 86%. In the same year, Hypercase study. This is another study that looked at another type of prescription of Tdf-FTC. Hypercase study looked at the efficacy of on-demand PrEP versus placebo for prevent HIV acquisitions in MSM populations. In Hypercase study, Tdf-FTC were given 4 pills per sexual encounter. They give 2 pills 2 hours to 24 hours before sex, and then 1 pill at 24 hours after the first 2 pills, and then the last pill, the 4th pill, were given 24 hours after the 3rd pill. This is the on-demand Tdf-FTC regimen. And in that study, they found that there was a reduction of cumulative incidence of HIV infection in people who received on-demand Tdf-FTC versus placebo. And in 2018 and 19, there was a study called PrEP study that conducted in Paris, compared the efficacy of HIV prevention of Tdf-FTC once daily versus Tdf-FTC on-demand versions. In that study, the first analysis was done at 7 months after study start. They found that there was no HIV infection occurred in both arms. So from the first analysis, suggests that these 2 regimens, Tdf-FTC once daily and Tdf-FTC giving on-demand prescription, perform equally for HIV prevention among MSM. For heterosexual populations, there are many studies, but in this slide, I'll focus on TDF2 and partner PrEP trial that look at the efficacy of Tdf-FTC in heterosexual populations. In TDF2 study, it includes 1,200 HIV uninfected heterosexual individuals to receive Tdf-FTC or placebo. And in that study, they found that overall protective efficacy of Tdf-FTC was 62%. Partner PrEP study is another large study that looked at the efficacy of Tdf-FTC, and placebo for HIV prevention among heterosexual populations. They found that the cumulative risk of getting HIV in Tdf-FTC were lower than TDF and placebo. So this study suggests that Tdf-FTC can be used in heterosexual population as well. This slide shows the overall efficacy of the HIV reduction in the study that I mentioned in the previous slide. You can see that the number of risk reduction ranged from 30% to above 90% in some study. It is depending on the adherence level of the populations. This graph shows the effectiveness of regimen and the percentage of drug level in the blood that convert to the adherence level of the populations. You can see that in study with high level of blood of a drug in the blood or high adherence of the participant, it's correlated with high effectiveness or efficacy of PrEP regimen. For example, in IPREC study and Hypercase study, the level of adherences of those 2 studies were very high, and confer high effectiveness of PrEP regimen using Tdf-FTC. So the effectiveness of oral PrEP directly correlates with its adherence. This is the major challenge for application because PrEP should be taken once daily and should be the people should adhere very well to the PrEP regimen. This is the challenge of using daily PrEP for the adherence. So in summary, Tdf-FTC has been approved for HIV prevention, and it works very well across the populations. Men who have sex with men, heterosexual individuals, people living with intravenous drug, pregnant women, and adolescents. However, there might be some issue on the long-term safety on bone and kidneys for Tdf-FTC use. This agent has generic version, and people can access to this medication at affordable price. And due to the generic versions, this regimen is practical for nationwide implementation from the government. For Tdf-FTC, this is a very easy regimen to prescribe. It works very well among MSM and transgender women. It may confer good adherence to the regimen because it is simple and use only 4 pills per one sexual encounter. However, in the study that looked at the efficacy of on-demand Tdf-FTC, they found some short-term gastrointestinal symptoms in people who receive on-demand Tdf-FTC. However, due to short-term exposure of Tdf-FTC, this regimen may be preferable for long-term safety, and Tdf-FTC can be accessed in the generic version and have more affordabilities and practical for implementations. Next, I'm gonna move on to new version of PrEP regimen using Tdf-FTC and long-acting cabotegravir for HIV prevention among men who have sex with men. These 2 studies conducted in 2020s. The first study is Discover study. Discover study, they compared the efficacy of Tdf-FTC versus TAF-FTC for HIV prevention. This slide shows the amount of tenofovir, which is the active ingredients for inhibition of HIV replication in the cells. Tenofovir from Tdf has some proportion that go to kidney and bone. However, tenofovir from TAF or tenofovir alafenamide fumarate, most of the tenofovir from TAF can enter to the target cell, and very minimal of tenofovir from TAF has systemic exposure that deliver to kidney and bone. So it suggests that TAF may have lesser long-term effect on bone and kidney. And Tdf-FTC can be used in combination with other antiretroviral agents for HIV treatment. However, TAF-FTC is now being evaluated in high-risk population for HIV prevention. The first study that looked at the efficacy of Tdf-FTC versus TAF-FTC is Discover trial. This is non-inferiority trial that look at the efficacy of TAF-FTC versus Tdf-FTC in men who have sex with men populations. And the participants were randomly received TAF-FTC or Tdf-FTC, and they look at the primary analysis at week 48 after getting the agents. And they look at the HIV incidence per 100 per year in both at 48 weeks and then at 96 weeks later. The study was conducted in North America and European countries. in the city with high HIV incidence. This is the results from the Discover study. The study enrolled a total of 5,300 individuals. 2,600 individuals will receive TAF, and the other 2,600 people received TDF in the TDF arm. The primary analysis, when they look at HIV incidence in both arms, there were 7 infections occur in TAF FTC arm, and 15 infections occur in TDF FTC arm. And HIV incidence per 100% years in TAF FTC was 0.16, and the incidence rate per 100% years in TDF arm was 0.34, and met non-inferiority criteria for the study. So the data suggests that these two regimens perform equally for prevention of HIV among MSM populations. This study also looked at the toxicity of Tdf versus TAF. First, they look at the bone toxicity. The study measured bone mineral density at hip and spine in both arms. And when you look at the figures, you can see that in people who receive TAF FTC has lower or changed in bone mineral density at hip and spine comparing to those who receive TAF FTC. This suggests that TAF may have less bone effects than TDF. And the other test for the study, they look at the effect of TDF and TAF on creatinine and sensitive tubular marker for proximal tubular pathway. When they compare the serum creatinine and creatinine clearance in both arms, they found that there was a significant change in GFR in people who receive TDF FTC versus TAF FTC. So you can see that people who receive TDF has declining in creatinine clearance comparing to those who receive TAF FTC at 48 weeks after randomizations. And for the sensitive renal marker for tubular, proximal tubular functions, beta-2-methylglobulin and retinol-binding protein, they found that in people who receive TDF has increased in the level of beta-2-methylglobulins and retinol-binding that may suggest proximal tubular pathway in TDF arm comparing to people who received TAF FTC. The study also looked at the weight gain and LDL in people who received TDF and TAF. In people who received TAF, there was an average gain for 1 kilogram, and there was no net weight gain in people who received TDF. And in people who received TAF, there was an increase in LDL, but small change versus decrease in LDL in TDF arm. So in summary, the incidence rate ratio of the study was 0.47. It was consistent with non-inferiority statistical results. And when they performed sensitive laboratory renal biomarkers and bone mineral density, they found that these two parameters were better in TAF arm versus TDF arm. However, there were no significant difference in clinical outcome between these two arms. So in summary, TAF FTC, it worked very well in many men who have sex with men populations and have more safety and tolerability. However, there might be some issue on price and practical for implementation in some countries. Next, I'm going to move on to long-acting cabotegravir for HIV prevention. Cabotegravir is an integrase inhibitor that can be administered as intramuscular gluteal injection every 8 weeks. And this agent is very attractive for PrEP options in high-risk individuals who are unable to adhere to diary oral regimen. So SPGN 083 is the first study that compared the efficacy of long-acting cabotegravir to oral daily Tdf-FTC for HIV prevention. This study looked at the efficacy of these two regimens in cisgender men and transgender women. There are 3 phases of the study. The first phase was the oral phase that used oral cabotegravir for 5 weeks, and then followed by injection phase that used long-acting cabotegravir 600 milligrams intramuscular at week 5, week 9, and every 8 weeks, and then followed by Tdf-FTC phase. This is the phase that happened after people stop taking injection of cabotegravir long-acting. They need to give Tdf-FTC to cover the tail of long-acting cabotegravir for another 48 weeks. This is the cumulative incidence of HIV infection in both arms. You can see that the cumulative incidence of HIV infection were lower in subjects who received cabotegravir versus Tdf-FTC. And there were 13 infections occur in cabotegravir arms, and 39 infections occur in Tdf-FTC arms. So the incidence per 100% years was 0.41 in cabotegravir arm and 1.22 in Tdf-FTC arms. And the hazard ratio was 0.34 in the study and met criteria for superiority. This is the sub-analysis of subgroup analysis in the study. And the table show the adverse events in both arms. So in both arms, there were comparable number of adverse events occur in for grade 2 and grade 3, and serious events. These adverse events were the rate of adverse event in both arms were comparable for this in the study. And in the study, when they look at the serious injection side effect that leads to discontinuation of injection of long-acting cabotegravir, they found that only 2% of individuals who received injection had to stop because of severe injection-related events. In long-acting cabotegravir arm, there was an association with average weight gain for 1.3 kilogram per year, compared with 0 kilogram per year in Tdf-FTC arm. This study also looked at the breakthrough infection or HIV infection that occurred in this study. For the cabotegravir arms, there are 4 people who had HIV infection before screening or during screening. So this is a baseline infection that may not associated with use of cabotegravir. In the other group, there were 5 individuals has HIV infection that occurred, but with very low level of drugs. So it means that the people in this arm did not adhere well to the medications and has failure because of no drugs level in the blood. And the third group, we call group C. There were 3 people who had HIV infections occur during the oral phase of cabotegravir. And in the last group, there were 4 people who had breakthrough infections during injection phase. And these 4 individuals have integrase associated mutations. When we look specifically in the last group of 4 people who have breakthrough infection during long-acting cabotegravir arm, it is observed that these 4 individuals have delayed antigen antibody seroconversions from the test. It might be because of the effect of integrase inhibitor that can inhibit viral replication during acute infections and cause low-level viremia and cause delay antibody detection by using 4th gen ELISA. So there was a delay for antigen antibody seroconversion in people who have breakthrough infection. That might be some practical problem for implementation of using long-acting cabotegravir, because we should have the better test for HIV diagnosis in this group. And the other thing that interesting in this group is when they fail cabotegravir, 2 people in this group has integrase associated mutations. So in summary, long-acting cabotegravir performed very well and was superior to daily oral Tdf efficacy in prevention of HIV infections among men who have sex with men and transgender women. Injectable site reactions were common in long-acting cabotegravir injections, but mostly mild. Only 2% has to stop having injections. And there was a delay in seroconversions in people who have breakthrough infection in long-acting cabotegravir prevalent. And we need to have the strategy for treatment after these breakthrough infections for selection of the subsequent regimen for the treatment, and we need the strategy that can prevent integrase resistance in the case of long-acting cabotegravir prevalent. There are something that ongoing for using of cabotegravir in another populations. HPTN 0.84 are now looking at the efficacy of this agent in cisgender women. And there are ongoing study that look for the tools for the diagnosis of HIV infection in people who use long-acting cabotegravir arm. So in summary, long-acting cabotegravir arm perform very well and superior to oral Tdf efficacy for HIV prevention among men who have sex with men. And due to long-acting property of this agent have very simple adherence and allow forgiveness for prescriptions. The regimen is very safe, and there might be some problem with affordability and practical for implementation for using injections. In the future, we're going to have a new agent for HIV prevention. This is another. This is an example of the agent that we are now we will be having and being under investigate. Fusion inhibitors and iscalavir. This is another nucleoside translocation inhibitor that can be modified to be a long-acting agent and can be used for both HIV treatment and prevention. In summary, PrEP can effectively reduce HIV infection in high-risk populations. PrEP requires user adherence. Right now, we have many tools for many PrEP regimens that allows simple adherence for people who want to use PrEP. And side effects of PrEP are minor and manageable. And we do have many PrEP regimens that can be applied in our population that have risk for getting HIV. And in the future, we may have alternative tools for delivery and provide for people with risk. Thank you very much.